Usually, how long do you think a mother and a father should start focusing on their health before they start?
One of the funny things that I hear often when we go for an early pregnancy scan, which is done transvaginally, is will it hurt my baby?
I want to call this as post-COVID pandemic in children. Developing a lot of attention deficit. Imagine you're watching the screen all the time and then you go sit in front of the blackboard.
So technology has come up and we also have AI coming into ultrasound. Like we have a checklist that the AI can help us with.
Then we feel, we are noticed, we are cared, and our baby is going to be taken care not just by me, but my husband.
Best thing that you can give to your children is good genetics. Okay, so work on your lifestyle and work on your health.
So it's not the last hope. It's not that if your IVF is not working, you're never going to conceive naturally. You still can.
These days, fetal medicine is really good brands.
For people who are not aware of it, it can be like a scary place. But what I would suggest is for those babies who actually need help, that is heaven.
Hello, everyone, and welcome to this panel discussion. Today, we're going to be talking about something that is deeply personal to many families: the journey to becoming parents. We've chosen the words "You made it" as the theme this time because these words mean something different to everyone. For a couple, it could be the moment when they first saw the 2 marks on the pregnancy test after years of waiting. To another, it could probably be the moment when they heard the heartbeat of the child for the first time. And to another parent, probably when they finally brought their little one home from the NICU. So whether it is watching your child achieve milestones or finally making it to school, you've all had those moments where you've said, you know what, we've really made it. And that's the beauty about this journey, that it's not about a moment. It's a journey filled with joy, hope, confusions, of course, a lot of questions and uncertainties. But the beauty of it is that you don't have to walk it alone. You have a lot of experts willing to guide you and take care of you throughout this journey. And today, we've brought all those experts in a single room to help us understand the journey of parenthood better. So let's get started. Hello, everyone. Thank you so much for joining us. Today, I feel like the tables have really flipped for me. And what I'm seeing here is very beautiful, right? It's a complete representation of the entire journey of parenthood. Right? We have an IVF specialist, a gynecologist, a neonatologist. We have a fetal medicine specialist, obstetrician, literally all the doctors we might ever need in the journey of parenthood. Right? So this is such a power-packed combo. I cannot wait to see what comes out of this conversation. So let's just do a quick round of intro. Tell us who you are and when do families or couples usually come to you for help?
Yes, so I'm Dr. Sharvari, gynecologist and IVF specialist. So people often come to us mainly for 3 reasons. One is before they start planning pregnancy. One is when they have tried pregnancy for a longer time and it is not going in the right direction. And number 3 is now that we have started seeing is people who come for freezing, egg freezing, sperm freezing, and embryo freezing.
I am Dr. Priyanka Reddy. I'm a fertility specialist as well. And I think I have nothing more to add. Sharvi's almost covered everything.
I'm Dr. Deepmala, obstetrician and gynecologist, Motherhood Hospitals. And at the time of planning to conceive, I'm the first go-to person for the couple. After that, when they conceive, I take care of them throughout 9 months and hand over the baby to our neonatologist.
Hi, I'm Dr. Pratap Chandra. I'm a lead neonatologist. So when do I meet the parents? It's at the most emotional state of their lives. I always say when a baby is born, a new mother and a dad is also born, right? So that is the time that when we actually meet the parents. Or sometimes when the babies are sick for various reasons, they get admitted to an ICU, or if they're born too small, too early. These are the times when we actually meet the parents for the first time.
Hi, I'm Dr. Anjali. So I am a fetal medicine consultant. I am involved in all the scans in the pregnancy. I'm also involved in doing some, suggesting screening tests for detecting complications in pregnancy. And I also take care of, genetic testing, which involves some procedures like amniocentesis, chorionic villus sampling, etc.
The entire house here. And one more thing I noticed is that we all have so many years of experience, right? I mean, one thing that is constant with time is change. And I know that since the first time you started as a doctor, there are so many changes that happen. So the way we understand the specialization also changes for us patients. So can you tell us in your own specialization, what was that one significant change that you noticed that perhaps changed the way we understand the specialization, or perhaps it changed it for good?
So something that changed was couples now getting more involved into genetic counseling. So there are certain diseases that run in the family. People are able to identify it. We are able to make genetic probes for it. And before the baby is actually born, that is, we can test the embryo before it is implanted into the female uterus. So this is something which is like a turning point, and people are getting aware about it.
Yeah, so I also feel like in the past 5 years, at least we're looking down, I think the approach itself has changed. Even in terms of the doctors, the way we look at patients, and even them, they're well aware of, because of our social media, they're well aware of, where they stand in terms of their health, whether they are looking at, we're also talking more in terms of holistic, right? We're not only talking about, let's say, fertility. We're not only focusing on how am I going to conceive in terms of taking a treatment, but we're also talking more about, whether you're getting adequate sleep, are you having any stress levels, how's your nutrition, how's your lifestyle per se. So I feel the approach itself has changed. Of course, clinically, we also have evolved in terms of, like how Sharvi said, genetics. We also have, our embryologists have, the screening techniques have improved, embryo screening techniques have improved, AI is coming in. So I think all these have definitely changed in the past 5 years.
They are telling that the research and technology that happened in the specialization has led to that change. I think we're seeing this a lot, even when I was scrolling through my Instagram, there are so many things where people are saying a mother needs to be physically fit. A father also needs to be physically fit because it impacts the sperm quality.
Yeah. So mental and physical health of both husband and wife matters for the healthy baby.
Usually, how long do you think a mother and a father should start focusing on their health before they start?
Oh, wow. So it's not just 1 day, 1 month or 1 year.
It's a lifestyle.
Health is from the beginning.
And what have you seen, Dr. Pratap?
I have seen loads of changes that has happened. Especially, we deal with a lot of machines, and I've seen these machines coming into helping these tiny babies. Lungs get much better. We can do very precision ventilation now. We try to improve a lot of things in other hospitals using artificial intelligence. Precision cameras have come in, Internet of Things, IoT, what we call. These things we use now. The technology has come a long way in helping us actually, in improving the outcomes of these babies. See, at the end of the day, what other people were suggesting as well, the family-centered approach has actually come into fore now, where parents were standing outside the NICUs and, they were just updated once in a day or once in 3 days, something like that. From there to actually parents are sitting next to the baby who's ventilated, not getting scared, getting used to things, and getting a lot of support from the nurses and the doctors. Along with that, they started to understand that their involvement, if it is more, that will help in the best outcomes of the babies. Example, giving the breast milk to the baby, what we call as kangaroo mother care, where like how the baby kangaroos will sit in the pouch of the mother kangaroo. Similarly, the baby sits, is lying on the mother's chest, and then that gives a lot of affection, lot of bonding, and therefore breast milk comes really well. So all these things we are integrating towards the better outcomes of the babies, and therefore the families are feeling much empowered in taking care of their babies even after the discharge.
Lovely. I think you covered a lot of points. Eventually we will be discussing more of this, because I think these are the things that parents are looking for, right? Baby, where is the baby? When can I see the baby? Why is my baby in NICU? So many questions. So
absolutely, we always tell them, don't worry, this is your baby, but we've got 10 other mothers for your baby. All the nurses are looking after the baby so well, with a lot of passion, compassion, and empathy.
And Dr. Anjali, what have you seen in your field?
So fetal medicine is an evolving field. Initially, it was more about, focused on the mother's age and any previous history and work on that and do a risk assessment. But now it has become a more personalized risk assessment, and we go in detail into history of each and every woman that comes to us, and then talking out a plan for her specifically. It's no longer a generic thing. It has become very specific and focused on the lady herself. Then we also have a lot of genetics coming in, and we can, based on the previous history, we can help the mother and the couple, go through the pregnancy and also do genetic testing, help them understand what to expect from it and also how to proceed from there. And another thing that I've noticed is that from a decade back, now it is more about a multidisciplinary team approach. So it is not just me. It is always the set of us. I find out something is wrong. The first thing I call is the obstetrician, take her in, telling that this patient has this problem. And then if once the patient is settled, then we talk to the neonatologist. And there are instances where we have had pediatric surgeons who come into the picture to counsel the couple so that they know what to expect if they go ahead with the pregnancy, what to expect after the delivery as well.
Wow. I think you exactly touched on what everybody said, right? There is change everywhere. So when one field is evolving, it is important that the other field also evolves so that it matches the care that they are able to give, right? I think that sets the perfect ground for us to start up to talk about the parenthood. We're going to be doing something very interesting right now. The entire conversation, we are going to pick a single case study and we are going to talk about all of these through that case study. Now, we've intentionally chosen this because this couple went through a lot of challenges that most couples outside face. And of course, we've given them fictional names for the sake of preserving their identity. So we'll be calling them Vijay and Priya. So the male is about 36 years of age and the female is 33 years of age. They recently got married and just like most couples, they're excited to have a baby. And they start trying. And very soon they notice that months have passed and finally a year has passed and nothing has changed. There is no positive confirmation of pregnancy. Now, this is where the couple is like, oh, is this normal? Should I wait more? Is this how long it usually takes? Is there something wrong with me? Should I go get checked? And this is the stage where a lot of couples are stuck. So at this stage, the one specialization they know is gynecology. They're like, let's go to the gynecologist. So when a couple like Vijay and Priya come to you, they are already coming after a lot of exhaustion. So what are you looking at? How do you decide that now is the time that they have to perhaps go and see a more specialized care? They will benefit more from an IVF specialist than me.
I get their basic fertility workup done. And if they are 33 and they have become 35, with increasing age of the women of marriage and conceiving, and maintaining good mental and physical health, I don't find, already 35. So I do basic fertility workup. If their fertility index are good, if their general health is good, and husband's sperm is good, fallopian tube where meeting of egg and sperm happens, then we just go ahead with few cycles of ovulation monitoring. If they don't conceive in few cycles because they have already tried for so many months or years has passed, I refer them to fertility expert because they are the better person after that.
Okay. So when you send them to the IVF specialists, right, what usually happens is when patients come to you, they don't come to you normally, they come to you exhausted. Because they have gone and see another doctor before, they have tried and they're like, this is the last hope. So they come with a lot of emotional baggage. So when you see couples like Vijay and Priya, what are some of the major emotional concerns that you see in them? And what are some of the physical concerns? Perhaps, Dr. Priyanka, you can get started.
See, most of the couples, like you rightly said, come to us with a lot of emotional baggage. The first consultation especially, we feel is the most important. We do a thorough history because we need to understand not only the present situation, we want to know what their past was, what all treatments were done, what is their understanding of the subject, because that's where we want to take it from, because we have diverse kind of patients, right? They're ones who have absolutely no idea of what's happening. So probably as simple as they don't know when the ovulation actually occurs. We have patients with that kind of, a background. We also have patients who know everything because of the social media. So probably they're aware of how IVF happens, and their questions are very different because we have to take it from there. So we want to first understand where their knowledge is. That's one thing. We also want to know what their background looks like in terms of, what's the past history, how physically active they are, what is their work schedule like? Because many people have sedentary lives wherein, it's a desk job. You have some who really have the job where it's a job where they move around a lot. So we want to know all these things. So the first consultation, mainly we're trying to understand the patient. It's not about jumping into a conclusion and saying this is the treatment that you need. We are trying to understand that where you stand in terms of fertility, your knowledge, and we want to have a background on that. So once we know this, then we are going to start telling them about, let's say, you need this kind of treatment or these investigations, what further investigations we can do. We have some patients who, even before they start trying, they probably would have done all the panel of investigations and they're there. So that's important. We need to also understand those things. So I feel like how you said, Priya and Vijay, they are of an age where they want to conceive, and we also don't want to push it any further because they've crossed that 30, they're close to 35. We say there's going to be a decline in fertility. We don't know how their lifestyle was previously. It's not that, they come today and we're going to, they're not going to have a child immediately when they come to us, because 3 months back, how their lifestyle was also matters to us. So we start from there. And also we want to understand what kind of emotional support they have at home. So listening to them, understanding what they want from us is more important. Treatment, to be honest, is quite standard. Everybody does the same treatment. So this aspect of understanding is important for us.
Dr. Sharvari, maybe you can tell me how, when somebody enters a fertility treatment center, right, they think, oh, they're going to push us into IVF. So is IVF the only fertility treatment option available? Is this a misunderstanding? If yes, what are the other options that we have?
So it's a completely, misunderstood field altogether. There are people, even when, like Dr. Deepmala said, she refers them for fertility consultation. So they feel, okay, the doctor is going to advise me IVF. Okay, so that is not true. Many times the people don't need actually any treatment. Okay, so there has been a lot of studies where people say that when the female has regular period cycles and when all the other parameters are normal, 80% of the people will conceive within first year of married life if they are being sexually active. Only the 20% need our help. So it starts with, like Dr. Priyanka already highlighted, the lifestyle. People are, more career focused. They are not probably trying in the time where they are supposed to try. There are only 6 days in an entire menstrual cycle where the female is fertile. So if you miss on that days, you are actually not trying fair enough. Okay, so we have to make them understand, like she already highlighted, the biology, and biology doesn't math. Okay, so 1 + 1 may not be 2. It may be 3, 5 when it comes to fertility. So if we begin with a very simple thing called as ovulation induction and timed intercourse, where we make them understand, okay, these are the few fertile days, and you can just try without any tension, without any stress, just try blindly, that's it.
So is this fertile period something that couples can check on their own at home, or do they need a doctor to tell?
So sometimes they need a doctor, sometimes they can check it at home, and there are very subtle signs that the female body itself gives. Okay, there are certain changes in the female body that happen during ovulation. If she is attentive enough, she will be able to catch it. And I personally don't advise people to, go behind ovulation kits, because again, that creates unnecessary panic. When you have regular cycle, you can just go with the cue of your body. And in certain cases, yes, take help of the doctor to understand. And, there's a lot of performance anxiety on the men part. When, you've been tracking, like I said, it doesn't math. So, when you are supposed to, when the wife comes and tells, no, this is the day we are supposed to do it. It's not like some mission or some homework that we are going to give it to you. So this is what the basic thing we do is ovulation induction and timed intercourse, followed by IUI, followed by counseling. And the last step is IVF. So not everybody, it is like a snake and ladder, I say. So only when some people will achieve their goal at the 4th step, at the 5th step. Somebody who has climbed 99 steps and now the last 100 step is the IVF.
So I usually say that fear resides where understanding lacks. So most of the time, the couples that walk in, they're afraid, okay, what are they going to do to us? Are we immediately going to be put on tests? Are they going to ask us questions that we may not know? So can you take us through what are some of the general information that they have to know about themselves before they come to an IVF specialist? Any one of you can take this up.
So I think, like I said, first history. It's very important. We want to know basic, your age, how do you work, what are your timings. We're looking at how your cycles are. I have some patients who say, I don't track my cycles.
So that's very dangerous, I've heard.
Right. We want you to track your cycles. We want you to know, at least you should be bare minimum is know when your last 3 period dates were, so that we get an understanding of your cycle. About what's the length of your cycle, how heavy is it, how light is it, that you have pain during your cycle. So basically a complete menstrual history. We also want to know your past in terms of if you had any previous treatments. We're talking about, it could be related to your thyroid medications. It could be, any metabolic PCOS, you can have diabetes. Please do let us know. I have patients who don't tell us until, like, see, tomorrow is the surgery, and today they tell us. After they go to the anesthetist, then they tell us that, this patient has an epileptic fit, which the history never showed us. Probably and they were like, we had when we were a kid. We never had it after that. We don't. Right. And you were put on medications for 15 years before coming to us. So why is it not important? So you should be able to know all these things, and you should be able to tell us all the surgeries, what kind of surgeries. I had a surgery when I was a child. Okay, what surgery? I don't know. It was in the abdomen. Now, which part? Because, your abdomen has so many various organs. We don't know which was the organ, and why did you really have that surgery, right? Even men, for that matter, they're like, childhood, I had a surgery. Now, I don't know what that surgery is. So please get back to us, get that information. You have your parents, you have your family to support you with those things. So get back to us with those kind of information. These are important for us. We want to know, when we ask you about your sexual history, we want to know, whether you're aware of the timing. They shy away from even talking to us about those things. It's important. It gives us an insight as to whether you're really timing it well or you're not, right? So when we even say, how is your work schedule? One is in morning shift, one is in evening shift. So where are you even really getting time with each other, right? So this is some of the basics that we do want. And same thing with the husband. We want the couple to be present during the first consultation. It's not always for the woman. We want the husband to be there so that, and they need to understand.
And they usually say, drop all your shame and shyness at the door of the doctor. Once you enter, you have to be completely honest, because then only your doctor will be able to help you better. And I think what you're indicating is more awareness of what's happened to you. You don't have to know what happened to everybody else. Just keep a close monitoring on what happened to yourself. I think that's a great takeaway. At this point, I want to open the question to everybody here. Like they were all saying, right? The patients have changed. So what kind of change have you seen in the patients? In terms of the age, or perhaps in terms of the awareness they come with? Because our lifestyle is changing. Our culture has also changed. So what are some of the key changes that you've seen in your own patient profile in comparison to, let's say, 10 years ago?
So I feel a lot of them have become more aware, but sometimes it's not in the right direction. Okay, they've been influenced quite a lot. And, it's great that people know things about their own children. I'm talking about my field. So it's good that they know things about their babies and all that. In our field, there is a lot of myth associated with the baby care, as well as in the child care. People put their baby in the sunlight to treat the jaundice, even now. But on the other hand, there are people who are looking at the internet, getting the phototherapy machine at home and then treating themselves. So you've got both the end of the spectrums. There is a transition which is happening with the old tradition, and then the newer people not accepting the tradition. And, a lot of conflict that comes in during this time. So these are some of the changing things that's happening. And I've seen, especially in children 1.5 to 3-4 years of age, a lot of them are not able to get the speech out because there is a lot of expressive speech delay in these children. The reason is the screen time. Yeah, too much of screen time, because there are almost 900 connections that are happening every minute in the brain. And majority of these are linked to interpersonal relationship and linked to speech and language development, cognitive development. And then screen is just one-sided signal, so there is no interaction in there. And the way these social media is devised is to get that dopamine released in quite a large instantly, and then there is an instant gratification. But then it need not have to stop there. You can just keep scrolling. So one is it's affecting the eyes, the other one is it's affecting the development. And What I've seen post-COVID is quite staggering. I want to call this as post-COVID pandemic in children, where they're basically developing a lot of attention deficit. Imagine you're watching the screen all the time and then you go sit in front of the blackboard. Which one is more, attractive for you, stimulating. So they're not able to sit in one place. They lack attention. Some of them develop hyperactivity disorder because of that. Some of them become very introvert because they're not able to communicate well. So these are some of the things that we are seeing, as we go along, evolving as new disease processes.
Dr. Anjali, I'm sure that there are newer technologies that have come into your field, right? Usually there is a sense of hesitation from couples to try on new technology because everybody who's done it before them are like, hey, we did it without this. We don't need any of these things. Why are we taking? Maybe we should go see another doctor, right? That's the common misconception. So have you seen a change in that?
Definitely. I think the main thing that every day I face is explaining patients why they need a transvaginal scan. Because
Can you tell me what's a transvaginal?
So previously, the main modality of scanning was on the abdomen. Expose the abdomen and use gel and then scan through the on the abdomen so that the rays go through the layers of the abdomen and then you see what's inside. That may be the abdominal organs or the fetus. So now, I think from the past decade, transvaginal scan has come in, wherein a transvaginal probe is inserted inside the vagina of the woman. And since it is closer to the uterus, the number of layers is lesser. You just have the vaginal, epithelium. You need to cross that, and then you can very well see the fetus and the placenta and everything very beautifully. Especially in early pregnancy, and especially when you're suspecting there may be some abnormality like an ectopic pregnancy or a cesarean scar pregnancy, it becomes very important to be able to accurately see where is the problem and how exactly can we deal with it as well. Because abdomen scan, by the time you actually reach the organ of interest, you have lost most of the information. So with transvaginal scan, you can see it very beautifully, and it in fact assists the gynecologist also to plan the surgery. But the knowledge about it is pretty limited, because especially the ones who come back with the second baby, they always have this question that first pregnancy, nothing like this was done. Why are you making me go through it? So it is a task. It is, more than the scan, it is explaining to them that it is necessary. I need to see this. I can give you more information. And then, yes, when it comes to baby, like parents, they always take the extra mile. So once they understand, that it is necessary, then yeah, it is beautiful and all that. Apart from that, now there is 3D scans that is coming to picture. So we can see the, normal and abnormal much more beautifully. So technology has come up, and we also have, AI coming into ultrasound. Like we have a checklist that the AI can help us with. And also the softwares that come along have evolved over time. So yes, definitely technology is helping fetal medicine as a branch.
So do you think patients are becoming more accepting of those technologies?
Yeah, I think once they see, we are the bridge. If we make them understand that, it is necessary and it is the thing that is going to give you the answer, then I think mostly they support it. There is definitely that uncertainty, which if we can replace with knowledge, I think, we can see results.
The more transparent you are, the much better they understand, and the much more open
empower them, tell them more about it.
And I think also to let them know that it's not harmful. It comes down to basically, the fear comes from there that, it's a new technology. Do I have to go through it, So I think letting them know that it's not harmful is also where because they even ask us, like in the first trimester after they conceive with us, you asked me for a scan. Now I'm asking you for a scan after 2 weeks to see the heartbeat. Again, like, will that hurt my baby,
Because they read a lot about radiation. So it must be consult. It's not a radiation. It's not going to harm.
Ultrasonic waves, basically.
It's ultrasonic wave, not a radiation. This concept is very much important for every couple. It's not going to harm. It will help.
One of the funny things that I hear often when we go for an early pregnancy scan, which is done transvaginally, is, will it hurt my baby? So they need to understand.
That's showing the probe and explaining a little bit makes a lot of difference.
Awesome. Thank you. The other thing we've noticed is that it is more emotionally demanding than it physically is. That's what we've heard a lot of couples say. The entire journey of parenthood in itself, right? That physically in itself, pregnancy takes a toll on your body, but equally it does emotionally. And a lot of confusion comes when the man is like, your male counterpart is like, okay, where do I fit in the picture? What am I supposed to do? All the scans are on her. I can bring her to the hospital, but what else can I do? So where do you think the male counterpart can actually bridge the gap?
See, these days we don't stay with a big family. For 90% of my patients, their husband is the one. They talk everything, they share everything, they go through everything. From the planning to conceive, through the journey of all those fertility treatment. And finally, when a girl is pregnant, it's not just girl is pregnant, the couple is pregnant. That's what I feel very wonderful or surprised also, and really compliment them. They take care of their wife. It feels scared. Then we feel, yeah, we are noticed, we are cared, and our baby is going to be taken care not just by me, but my husband. Earlier, husbands were unavailable, only focusing on earning. But nowadays, from taking care of 9 months to changing the diaper of the baby also, feeding baby. In fact, KMC is not done by just a girl. Holding the baby on the chest is done by the parent's husband also. In fact, I see in my delivery room, husband and wife both want to do skin-to-skin contact. Whatever religion they belong, they want to chant something good. Ki first word to my kid ear should be something very nice. So I really feel amazed and very nice experience for me as a gynecologist. It should be like this. People are progressing, and that's the need of time.
Like what Dr. Deepmala said in the NICUs as well. The mnemonic for that is a KFC, not your chicken. They're the kangaroo father care, basically. So yeah, so we just they just love it in the NICUs, and they're very much hands-on. To such an extent where sometimes I even tell them to just go easy. You have not given birth to the baby. That's your wife. Just let her relax a little bit. Don't keep giving the baby to mom just for feeding all the time. Always calculating the things. Always going on to the ChatGPT nowadays. And before they come to see us, they would have formulated a lot of questions and they know a lot of answers as well. It's very good in a way, but then if they get it clarified, because nothing is tailor-made what is available. It's a very generic thing. So it may not be suitable for your baby.
Wonderful. I think what I'm getting from all of you is that your journey does not begin just by entering into a fertility center or going to a doctor. You do your own personal research. Right. I want to take us back now to the case study that we were looking at. So it so happened that Vijay and Priya went ahead with IVF as the treatment. And that was their last hope, according to them. And their first treatment through IVF was unsuccessful. Now, this came down really hard on them. They were like, we thought this was the last thing for us. If this also failed, what is left for us? So I have two questions here. How do we work with patients who have a first unsuccessful IVF? And what are the next steps for those who have an unsuccessful IVF? Perhaps we can start with Dr. Sharvari and you can tell us about what are the next steps.
So basically, when an IVF fails, it is really disheartening for the couple. It is heartbreaking for the doctor and the embryologist as well, because there is a team which is working behind the entire case. Okay, so whether it is monitoring ultrasound, whether the lady is taking injections, everything is being followed up very meticulously, very closely. The hormone levels are being checked. And at every step, we do inform the patient that these are the number of eggs that we are expecting. This is the quality that we are expecting. And these are the embryos that we have got. And even after everything, if it doesn't work, then there is a need of looking much deeper into the case. Additional tests may be required, which is not done as a primary treatment for everybody. So be it genetic test of the embryos, or be it test for the uterus, be it hysteroscopy, be it uterus receptivity test. There are other tests available which are advised only after eliminating possible causes. So many times I come across people who don't take lifestyle very seriously, and it takes an, actually very sorry to say that, it takes an IVF failure for them to actually realize ki no, now I have to quit smoking, or now I have to, focus more on my sleep cycle, or now I have to actually go and start doing exercise. So when all the obvious reasons have been ruled out, we again go back. Okay, it is always retrospection, that what could have been done, better, or what is something that we can do additionally to improve our chances. And yes, IVF, no matter what people claim, 100%, 90%, I would like very honestly and blatantly tell everybody, do not believe a doctor who says IVF guarantees you 100% success. Okay, otherwise we would be sitting in temple, not in the hospital. Okay, so any success rate of 60 to 70% is globally accepted, and every doctor should be very transparent in the beginning itself. Every patient, even any case of two couples within the same age group having pretty much similar lifestyle also may have different outcomes. Okay, no two people are same, not even two sisters are same, not even two twin sisters married to twin brothers could be same. Okay, so this is how the personalized care steps into.
I think your environment that you grew up in and your personal lifestyle brings that difference, right?
And genetics, most important. The best thing I always tell patients, the best thing that you can give to your children is good genetics. Okay, so work on your lifestyle and work on your health, so that is what healthy genes you pass on to your kids as well.
And Dr. Priyanka, is this the last hope, or do couples have something else to look forward to?
No, to be honest, I'll tell you one thing. We've had, I think even Sharvari will agree with me, we've had many patients who've conceived naturally even after an IVF.
Yes.
Right, so it's not the last hope.
So
it's not.
Couples keep trying even though they opt for IVF?
Of course, yes, definitely. So we even give them break months, right? If she's had an IVF today and then she's not conceived in this cycle, we don't immediately go for the next cycle. We want to give those breaks. We give them at least 3 months, 3 to 4 months. See, every cell cycle is about 90 days. So if you want to start any kind of habit, you want to change anything, do it for 90 days, because then there's some change at the basal level. We're talking at a cellular level, right? So we always give them that time. And we know that, like, for example, the endometrial receptivity keeps changing month on month. So giving those breaks also help. And in between those breaks, we ask them to have, try naturally and have intercourse. And they're going to conceive when they least expect it. It's never when you say, this month I need to conceive. I have patients who come down and say, doctor, we've tried so long. I have a lot of stress from my family. I need to conceive in this next 2 months. It's not going to happen that way, because that's how much stress you're taking. If you're taking so much stress, how are you even going to conceive? Whenever you have stress, so how does your body perceive it, right? Your body is going to perceive that, okay, this is stress. I'm going to give more preference to brain, heart, and not the reproductive system. So it's going to shift all the focus to your brain, your heart, your vital organs. So what shuts down first is your reproductive system. So if you're going to be constantly in stress and pressure that I need to conceive, I have to conceive, it's not going to happen. In fact, I can give you an example. I had a patient who's been trying for, let's say, 10, 12 years. Okay, finally they had come down, not from Bangalore. They came down and said, we'll, get done with an IVF. We'd also seen that, she's done all the treatments and probably IVF is what we're looking at. So first month is normally where we retrieve the eggs and form the embryos and freeze it. Then the subsequent month is when we go on to transfer it. I give her a month break in between. She conceived naturally in that break.
Wow.
So I have the embryos with me, right? And she's conceived naturally. She's going to have her second child also naturally.
Wonderful.
So it's not the last hope. It's not that if your IVF is not working, you're never going to conceive naturally. You still can. Unless, if you say the husband has absolutely extremely less sperm count, there's zero and we have to retrieve it surgically. These are cases where we say this is direct IVF indications. Blocked tubes. Over here, of course, but the ones like we're talking about, the unexplained infertility, it can just be a simple factor which is probably stopping them. And it's about time. As you phase out of that, it's going to happen.
Successfully, Vijay and Priya did have a baby through IVF. And they were telling us how we thought that was the last step. But that just seems like the beginning of it all. Now we have so many more questions, so much more specializations that we have to go and consult. So we are completely confused right now. And the biggest question in our mind is, this baby was not conceived through traditional methods. So is this a high-risk pregnancy? Is that true?
So basically what happens, there are two different things. One is IVF, which is a mode of conception, mode of getting pregnant, and other is delivery or pregnancy, mode of getting delivered. So two different things happening. And what I tell people is it is their own sperm and own egg, and mixing of them is done by us. That's it. Otherwise, whatever the baby is supposed to be born out of a natural conception or an IUI or an IVF, because it is going to carry the same genes, there is technically no difference between the baby. But many times the IVF is advised to people who are already hypertensive, diabetic, they have some comorbidities, autoimmune conditions, that conditions like PCOS, that itself puts them at a risk of high-risk pregnancy, which may happen.
What is a high-risk pregnancy, first of all?
So, high-risk pregnancy is a very broad term. If we say even anytime the pregnancy can become high-risk, maybe a pregnancy going on smoothly, some placental issue come into picture, like maybe low-lying placenta, some bleeding issues, or to begin with, she is elderly, primigravida, or we say somebody who is getting pregnant for the first time after 38 years, somebody who has had previous history of multiple miscarriages. Okay, then there are certain cases where patient is on some other medications for, say, rheumatoid arthritis, so or a twin pregnancy in itself. So these are all a broader, multiple things come into high-risk pregnancy where there is a risk of, something happening to the mother or baby. So they are carefully monitored. That is what is high risk. They need more care, more monitoring, and more attention towards the entire pregnancy, more visits probably. So no difference between the pregnancy per se, but yes, there are underlying conditions. Fibroids maybe the female may have. So again, that may put the pregnancy at a high risk, not the IVF.
Great. So it's not just the IVF, but your underlying conditions that can complicate the situation that makes it high risk. So you don't have to be afraid about IVF in itself.
It's done.
Okay, great. This is where I think we move a little bit to the scanning, right? Fetal medicine specialist. Most people hear this term for the first time. The most term they're aware with is gynecology, right? So how do you help patients understand your role? How do you work with them to understand that in this phase, this is what we will be doing together?
Okay. So mainly, we are a referral branch. Mostly the obstetrician is going to refer to us. And previously, the concept was mainly they come to a fetal medicine specialist once they have an abnormal report or they've been referred to us from elsewhere. But now it is not so. We are involved right from preconception, like even before conception, they've had previous pregnancy complications. There's some abnormal genetics in the family. So even before they conceive, they come to us and we help them, chalk out the whole plan. What can be done? What are your options? Whether you want to go ahead with the pregnancy or you want to do a genetic testing and then proceed with the pregnancy. And also optimizing everything, right from diabetes, hypertension, everything. We want to optimize everything and then proceed to the pregnancy.
Take care of the monitoring.
In pregnancy, yes. In pregnancy, so the main window is our first trimester scan that is done at 11 to 14 weeks. So I think the general population is not aware of its importance. It is very, very important because that is the window where we can do most of the prediction that happens in fetal medicine. So the mother's age, her, history, as well as her, height, weight, her blood pressures, everything is taken into account along with the scan parameters. And we're able to predict, because of the newer technology, we're able to predict whether that particular pregnancy is at high risk of developing something called preeclampsia. That is, hypertension that happens in pregnancy, or is the baby going to grow small later on, or is there any risk of the baby being born earlier, which is called preterm birth. So, and also risk assessment for genetic abnormalities, mainly the chromosomal aneuploidies. So all this happens in that window, 11 to 14 weeks. And why it is so important is there is treatment. Like to reduce the rate of FGR and preeclampsia, we can put the patient on something called aspirin, and that needs to happen before 16 weeks of.
And it's usually not an over-the-counter medicine, it's usually prescribed.
So a lot of effort goes into screening all the pregnant ladies to identify those women who will benefit from giving this aspirin. So all that happens before 16 weeks. So the first trimester scan is the most important thing, and that is where we come in as fetal medicine specialists. Apart from that, we have the targeted anomaly scan where we look at the baby in detail. And yes, if there is an abnormality, then the course totally, differs, and then we go into a lot of counseling and evidence-based information is given to them so that they make a choice regarding the need for genetic testing, no genetic testing, or they want to go ahead and terminate the pregnancy. But now, definitely, because there is so much awareness, people do go ahead with pregnancies. And another advantage that we have is because in the previous decade, like a baby which has a lung deformity or it has a heart defect, a minor defect. There are many couples who have gone ahead with the pregnancy, delivered, and then the baby is treated and the baby is doing well. So the parents have been kind enough to, stay in touch. And now if we encounter another fetus with the same problem, they come into picture. They are so helpful. They, advise the new couple that, it's okay. It's not the end. Yeah. It's not the end. There are solutions, available, and who is good, what is to be done, what to expect, everything. We are there. We are definitely there. The neonatologist is there. But yeah, like you said, a peer group by themselves, they are able to support each other better. So there are more couples who are, ready to take the extra mile, even if there is a small abnormality on the scan.
These days, fetal medicine is really good branch. Hormone imbalance is the imbalance of estrogen and progesterone. In that, there is problem of ovulation, there is more estrogen. That causes a lot thickening in the wall of the uterus. And mouth of uterus that holds pregnancy for 9 months inside is getting weak. Although we don't realize when we just take care of PCOD. With increasing hormone imbalance, uterus is hard, so it tries to push the baby out. And lack of progesterone because of hormone imbalance, mouth of uterus is getting weak. So earlier, it was only 3rd month as a first anti-scan to rule out genetic. Nowadays, we get a scan done in between, when placenta is forming in 2 stages. At early stage, we know that, okay, this is very hard uterus, blood flow is happening very less, so we might deliver baby in 7th month, 8th month and all. If we know this problem at earliest with help of fetal medicine, then we start with baby aspirin, blood thinner injection, and we carry it till 9 months. Many a pregnancy I had, they came for second time to me. They told I have delivered only 1.2 kg baby in first pregnancy. I started, no, there is blood flow because of stress, high stress or family history of hypertension. I started baby aspirin, blood thinner, and with their timely intervention when blood flow is low, increase the dose of medicine, and we carried many a pregnancy successfully till the end. Baby didn't require an ICU stay also. They went to mother's side. Other part, what I am saying, because of weak mouth of uterus, earlier people used to lose their baby in 5th month, 6th month. Suddenly, without realizing, they will have water leak or baby coming out. Miscarriage in 5th and 6th month. Nowadays, they do the internal scan. They tell me cervix feels soft or cervix angle is less, or sometimes there is length of the cervix is less. So what we do, we tie very small procedure we do and successfully carry the pregnancy till 9 months. So fetal medicine, first of all, time to time they make you aware that you have to change your way of treating, where to add the treatment, what extra care you should take so that pregnancy outcome is successful. That's why whenever there is any pregnancy, any red flag, we keep interacting time to time for the very good result.
Actually, most of our patients have become like a family. They're here. Every alternate day they're coming. And even before they come for the scan, we know that she's in the emergency. She's going to come next to me. So we make a slot. We make sure that,
we accommodate them.
Yeah.
So there is an emotional connect with your patients. At the same time, there is a collaboration between the gynec and the fetal medicine specialist, is what I am getting.
For 9-month care, this collaboration plus time to time picking up the red flag area and taking promptly care of that is very, very important in 9 months of care.
Okay. You are mentioning about how these scans are important. I want to ask you, Anjali, how many scans are really needed?
So, there is a checklist, yes. But it is again, now everything is gone into a personalized, risk assessment and plan accordingly. Because somebody who has, had previous miscarriages, previous ectopic, definitely in early pregnancy only we're going to ask for 2-3, maybe another scan extra. because we want to make sure that this does not turn out to be an ectopic pregnancy. So we have the early pregnancy scans. The most important one is the NT scan that happens at 11 to 14 weeks. Then at 20 weeks is the anomaly scan, which is equally important. And then
is when the baby's organs started.
yeah. No, organs are already developed.
Okay.
But that window is the best window. 18 to 24 weeks is the best window for us to assess. So that is when we do the anomaly scan. And beyond that, it is more about the growth of the baby, whether the environment around the baby is satisfactory or is anything looking abnormal that needs to be addressed. So that is all a growth scan that comes later on. So routinely, there is a fixed set of scans. But then if there is the mother has a previous child with a cardiac abnormality, or she is known to have diabetes and hypertension, and, like ma'am said, you already know that, her uterine blood flows are less. You're expecting the baby to, grow small. We need to pick it up. Because the earlier we pick it up, we can first thing, the parents are aware if maybe she's not taking her diet properly, so we correct that, and we make sure that she comes for visits regularly, and we don't miss out on anything. And another thing is the timing of delivery. We can time and plan delivery and make sure that there is a fine balance between keeping the mother safe as well as avoiding extreme preterm, just because of these complications. So there is a fine balance that we need to reach, and that again the whole team comes into picture, and then the timing of delivery is decided, and then the delivery is planned.
I want to tell you something what happened with Vijay and Priya. So in their 20th scan, the couple found out that there is a small finding in the heart of the baby. And that is all they know. They don't know what the finding is. And the doctor communicates this to them, and they're really worried and frightened. The doctor is reassuring them, saying that this is a finding that may eventually go away as the pregnancy progresses. But for a couple, just like Vijay and Priya, there might be many other couples who come at this point where there are challenges of certain red flags, as doctor was talking about. These red flags, how do you communicate them to the patients in a way that they're not frightened, and also in a way that it's not falsely reassuring?
Okay. So this does happen quite a lot because, and yeah, definitely if it is normal and abnormal, the counseling is clear cut, because the counseling is going to go in two different directions. We know that. But when there are these subtle findings in the gray area, it definitely becomes much more difficult. So in this, what my role would be is giving them the whole spectrum of possibilities. Like what to expect. If it totally normalizes, then what is the follow-up? If it does not, it keeps on progressing, then what is the follow-up? And we give them a plan. Even if it is in this end or that end, there is a plan in place. If it is not going to resolve, then what? Then as the pregnancy progresses, we are going to monitor it, and then maybe immediately after birth, get a scan done, and then refer you to a pediatrician or a pediatric surgeon. Then what happens from there? So that is the worst scenario. But they know that for each scenario, there is a plan in place. I think replacing that uncertainty with knowledge, definitely that is going to convert the fear that is there into confidence. And that's where we take it up.
So in the case study that we were looking at, right, they had to go for an early delivery. So they were delivered at the week of 35. Now, my question is, how do you decide, or what are the parameters that make you decide that this couple will benefit from an early pregnancy?
Early delivery, because, yes, correctly you asked, first of all, 35 week is not early. It's a beautiful time to reach. In fact, when we start with so much stress, all working girl coming to me, reaching 9 months is the scenario where we celebrate each journey. We have reached 9 months. Second thing is, if there is increasing deterioration of the medical health of the girl or blood flow to the baby, then we decide this uterus is no more a safer place for the baby to be there. Our neonatologist, doctor, our friend can take care of the baby and give mentally and physically healthy baby. So rather than compromising baby inside the uterus, let us keep outside, take care of it for the future of baby itself.
And I think, Dr. Pratap, this is where you come into the picture, right? Mostly what happens to the couple, those few minutes after the delivery is the blur moment. They don't know what's happened. They don't know where the baby is, because there's a lot of emotional intensity during that time also. So can you tell me what exactly is happening during the transition of the baby finally coming into the neonatal care?
a lot of times, even before that, we would have seen the parents, especially if the fetal medicine scans suggest that there is a problem with the baby. Right now, I have a baby where there is a diaphragmatic hernia. For example, all the tummy contents are sitting in the chest. This baby is now better, almost going to go home in the next 2-3 days. So we have already established a relationship before the baby is actually born in those circumstances. In these cases where things have been corrected and no major problems, then we encounter the parents for the first time at the time of the delivery. So we are there ensuring that, the baby takes its first breath, get the oxygen into the lungs, heart starts working well, and then make sure the all-important oxygen gets into the brain. So these are the things that we'll be looking after and get the baby into the NICU. It is a very stressful period for them because people think it's all of machines and my baby is going to go there. And then, there's a lot of myth associated. So first thing what we do is to show them the baby before we take them to the NICU, both the mother and the father.
And we discuss before delivery.
Absolutely.
All three of us sit together and make them aware so that it should not be sudden tension on them what they are saying. We all three sit, we all three counsel, and we all three assure that it is a transient phase. Let us take care of it.
And being born at 35 weeks, I should be very positive in counseling. I just have to tell them that don't get worried. We just have to make sure that your baby is going to maintain its temperature well, take the feeds very well. And let's involve the mother as soon as she is, ready to come and see the baby. Let's reunite mother and the baby as soon as we can. So the rest of the things depend on what is the condition of the baby at the time of the delivery. So majority of the 35-weekers, they do really well, maybe a day in the NICU. And what we have developed is called a transitional care where, even if it's a small baby stays in the room with the mother and the father. We give them a warmer there. We have the NICU nurse staying there to help them out so that, the anxiety levels are reduced. Mommy and baby are not separated. So that's called a separation anxiety. Then this will also hamper the breastfeeding. So all of these can be positively looked into. Obviously, if the baby needs a lot of help, I think that is what we have trained all our lives to do. So anything that happens in US, UK, we can do it in Bangalore, for example. So things have gone so much in advance. I think, we know now we are very confident in looking after these sort of babies.
Wonderful. All right. You've been telling a lot about NICU. So what really is NICU?
NICU, if you want to expand it, neonatal intensive care unit. So for people who are not aware of it, it can be like a scary place. But what I would suggest is for those babies who actually need help, that is heaven. So not all babies need NICU support. Usually the general understanding is around 8 to 10% of all babies who are born around the world may need some sort of a neonatal intensive care help. And the degree of help depends on how sick the baby is or how premature the baby is born. So in a way, if I want to say, I think the Indian mortality rate of the babies have actually started to come down for the first time quite dramatically. Although in pockets it's great, in pockets it's still not. And a large contribution for that would be because of the presence of large NICU units who can actually cater and deliver a holistic care involving the parents so that the outcomes are much, much better. Previously, I know when I came to India about 10 years ago, I was told all the stories where the gynecologist refused to get a baby who's 28 weeks admitted to the NICU, thinking that these babies will not do well, and that's the families will suffer a lot. But as I say right now, there is a 23-weeker baby in my unit as we speak who was born just at about 400 grams and recuperating now, and hopefully within another 3-4 weeks, it should be heading home. And then that will be a very, very happy, journey for the parents, as well as, what I say is it becomes a memory as you go along, as the babies and the children gets bigger. But what they do later on in life, how well they, take care of themselves, how independent they become, that story is what the child will write later.
For the baby of Vijay and Priya, the baby was in the NICU for 12 days. Now, what determines how long they should stay? Is there a standard duration for which all babies are taken in? Or again, like you said, would it differ?
Yeah, it definitely differs from every baby. And standards are set so that, there is a rough idea so that you can give it to anybody. Born at 35 weeks, needing 12 days, slightly more, most likely baby needed a bit more help after the delivery. And there is no calendar here. So what we suggest is for parents to look out for 2-3 different things. One, is your baby breathing really well without the need of any oxygen? And secondly, is your baby gaining weight, just the trend of weight gain and not losing weight all the time? And the third thing is your baby taking full feeds really well? Okay. And not just that, just when the babies are starting to get ready with this, now the baby has learned it. The parents have not learned it. So it's the first time for the parents. This is where the transitional care comes in. And this is where we empower the mothers to, breastfeed and then teach them how to do the palada feeding or the cup feeds, and even as simple as nappy change and things like that. Because if the babies are small and if they've come from the NICU, even the grandparents, they're worried. They feel like the babies are very delicate to even touch, So there is a lot of myth that goes around it. So while staying in the hospital with us, with a lot of nurses' involvement, with the doctors and all that, they become very strong by the time they are ready to go home, both baby as well as the parents. And then during this time, we also suggest them to make sure the house is clean. There's a nice place for the baby to go in. Any elderly people, small children, are they vaccinated well? So these are small things that goes in a long way to help them.
When we were initially talking about NICU, right, you mentioned how parents are involved. So how much access do parents have when the baby is in the NICU?
Yeah. So this has changed quite a lot. For example, in US, in some places in India also, the NICU is run with the parents inside there 24/7. Sometimes it can become a little scary for the parents, but this is how much it has evolved. So in our unit, for example, we bring in both parents in the morning, and then we counsel them. We tell them what happened all night. Then they go and sit next to the baby and do a lot of kangaroo mother care and kangaroo father care as well. If there are twins, both those get on there, or one father and mother is holding the baby. So these things happen, and we generally encourage them to stay as much as they can, because mother has had either cesarean or a normal delivery. She needs rest and she needs to lactate and do a lot of things, hygiene and everything else is very important. So she'll have to take care of her health as well. So as much as she can, we allow them to be there in the NICU. And, they will be part of the care of the baby, although they're scared to start with. I just tell them your baby won't bite you, just touch the baby, So that from there we start to the place where they just take the baby even on home oxygen in some circumstances. That much empowered they are by the time they're ready to go home.
I think I really want to touch upon something that you mentioned. You said, the mother is also recovering. Usually what happens is that all the attention is on the mother until the baby comes out. Once the baby is out, unfortunately, in some circumstances, even by family members, the mother is abandoned. It's the baby that you're looking or giving more attention to. So what is the kind of care that is given to a mother while she's just out of the delivery room? And how do you think the family members or other extended people can care for the mother?
It's very important. One of the doctors earlier said, basically, it's not just the mother who gets pregnant, it's the couple who gets pregnant. At the same time, the whole family members, if they get involved, it doesn't matter. She will be lactating. She will be doing a lot of other things. She will need nourishment for herself. She will need nutrition for herself. Dehydration is a big part that we need to take care of. At the end of the day, the whole family should act as one unit and support the mother, because there is already a separation anxiety. She doesn't know what's happening in the NICU. If she gets stressed, she won't lactate. The milk will stop, producing. And that's detrimental for the babies, especially the small ones when they're in the NICU. We don't use the formula feed and all that in the NICUs. So mother's milk is the best, and like how we don't forget to give medicine to the baby, the antibiotics and all that. Same way, we always try to get the mother's milk within the first 1 or 2 hours, even if it's few drops to paint the baby's lips even, so that it gets colonized with normal bacteria what mother has got. So the science starts from there. So therefore, as much care that we need to give it to the baby, it's very important we look after the mother. Not to forget, the stress that is involved and the postnatal blues. All our people here knows much better than me because of the hormonal imbalances. So this is where I think we need to give her a lot of TLC.
So we focus on their food. If you want to give a healthy milk, your diet has to be healthy. Otherwise, from where you will get milk? And milk production is not just a job of the breast. It is here because prolactin is released from the brain. If you take too much stress, if you don't sleep, if you keep crying because of these hormone changes, then definitely what you want to achieve is not possible to do. Just because we want, we have to do. I ask husband, sometimes it's okay to cry post-delivery, but don't make it a big scene that why you are crying, what happened, did you get hurt, did you want this baby, it's normal, didn't happen, that's why. Yeah. And the girl doesn't know why she's crying because of hormone change. So give her some time. Don't be always...
Don't overwhelm her with the changes you're experiencing.
And don't think that someone is at fault. It's just the hormonal change. Go for a walk. Go for fresh air walk. It won't harm. And it will clear your mind.
So what I'm understanding is that there is care and attention and preparation given to the couple before they reach this stage. And I think that's beautiful. And I think that's a progression that we've seen perhaps, which was not there, let's say, 10 years ago.
And all of our psychological counselor also in each center, they keep talking to them. So it helps.
Now, this is where the parents are finally out of the hospital and they're taking care of the baby on their own. And that's a whole new anxiety in itself. What do we do? Nobody to monitor like how we had them before. This is where pediatricians really come into the picture, right? So how often would you suggest that families like these come and consult you? And how important is that first year? What are some of the milestones you're looking for?
For the first year, it's quite big. I'll just divide that very quickly. So especially after the discharge, we want them to come back in 2 to 3 days. The reason is that is when, as you said, they're completely lost. We always advise them to keep a note of what are the things that they're worried about, because, as much as we say, mothers after the delivery are very forgetful for whatever the reason, the stress and all that stuff that comes with. So they write down and come. And this is a very calm environment in the clinic. They can sit there and then discuss whatever the issues that they're facing, whatever the myths and all that. However, a lot of mothers and fathers say, okay, it's a very silly question, but no question is a silly question. It's just that you are bothered with it itself shows that, it's worrying. Correct. So we try to help them out. Lactation is the most important thing in that post-discharge time. A lot of them would not have understood what we have told them, just after the delivery. And then, now again, the lactation counselor comes into place. So we identify those things. We reassure them what they're doing is correct. We tell them some of the things like the myths Dr. Deepmala was mentioning. People want to know, when do we have to massage? People want to know, when can we give bath? How do we give bath? How do I cut the nails? What do I do with the jaundice? While giving massage, do I milk the baby's breast? This is a practice which was even followed in England, for example. This used to call witch's milk. So these are a lot of these questions, they just come there and confuse them. And, in Indian circumstances, it's great. A lot of people to be around. But then a lot of people are doctors also at the same time, when there is a newborn baby is born. So this is where I think things get confusing. So we have to empathize with them, make sure that, they follow the right journey. And to describe each one of them is quite hard for me to do it in this place. However, what they have to see is different milestones when they're growing up. How do they feed? How much is the growth that they need? Around 150 to 200 gram per week is enough. In the first initial few weeks. Then we follow the growth chart after that. We reassure them that not all vomiting is a problematic one. Small amount of posits that happens in the babies is quite natural. We teach them, the gentle massage is what we need for the baby, not a very vigorous one. Because, they're not weightlifters or anything. At the end of the day, this is done for developing the bonding. Because a very beautiful hormone called oxytocin is released. This is also called the love hormone, so which helps in bonding. So I ask them to do themselves, not using a masseuse and all that stuff. So it is great if you do that. So after that, give bath. Some people do it every day. That's okay. Some people do alternate days. That's also okay. So use gentler soaps, which are designed for the babies, gentler shampoos. So these are some of the things that we suggest. Just after the birth, and all this information is very much new for them. Even if they have had the first baby, it's new for the second baby. So then we take them on the journey of vaccination, continued breastfeeding up to 2 years. By 6 months, we teach them what are the things that they can give as food, which we call as complementary or the weaning food. And then, every milestone as the baby is achieving. All of this will go, hand in hand, and we don't let them go just like that. So almost every month there is a vaccination in the first year of life. That's a great time for us to discuss the growth, the development of the child, as well as the well-being. Okay, so this is how we handle them, and that is very important for this thing, because we see the difference when this doesn't happen. A lot of times, they would have struggled quite a lot during their, after the baby is born.
I think I'm just realizing as you're speaking that there are so many more things that you need to be mindful of. And of course, you have help and support at every stage, right? We were looking at how from the IVF specialist to the gynac, and even when we're doing scans with the fetal medicine specialist, and until the time when you're seeing your baby achieve milestones, there's help everywhere. All you have to do is track them. That is your personal responsibility, and then always be open and honest about it. I think we've had a fantastic discussion. For me, just listening to the entire journey of this, it makes me feel like it is a long journey. But of course, it's not a journey that you're walking alone. There are people at every step of it. And that's beautiful. So we're going to get into something fun. We're going to do a quick rapid fire. I'm going to ask one question to each of you. Please tell me the first thing that comes to your mind. Okay, we're going to have only one round of it. So let's hope we are able to be quick. I'm going to start with Dr. Sharvari, and then we just progress. All right. One fertility myth you wish would disappear.
IVF is only for older couples.
And one fertility fact that you wish people would remember.
I feel like, first of all, they should, understand that it's not 100%. Okay, one thing. You are going to be disappointed and you're going to have those fears. And we want to talk about how to overcome that. So I think that's very important, that they understand that it's not 100%. And like they tell us that we've had all the treatments. Now IVF is the last stop. Especially the first transfer, like you told me. Right? So they want that to be 100%. It doesn't work that way.
So have realistic expectations. Okay. One question every couple should ask before they try to conceive.
They should clear their all doubts.
Not pregnant in the mind. I'll remember that.
They should clear their all doubts. I'm not a judge. I'm just a gynecologist. Both of us want a healthy outcome.
And for you, one thing parents can do to stay connected with the baby while the baby is in the NICU.
Basically, get involved. Don't get scared. Okay? Baby is in NICU. It needs help. Doesn't mean that always it's going to be bad. So your baby needs help. That's why the baby is there. So connect with your doctors. Have a chat with the gynecologist as well as the pediatrician. Make sure that you're reassured all the time.
And one pregnancy concern parents can approach with a little bit less fear.
probably the whole IVF thing. They need not be scared of the whole thing. Like it is easy for some, it is not. But yeah, it is approachable and you don't need to have the fear.
I know you all have so many years of experience. If in one sentence you want to combine that experience, I know it's challenging, but as an advice, if you want to wrap it up like a toffee and give it to a couple who's watching this, what would that be?
So I would like to say that every time anybody comes for consultation, so every time they are like looking forward, like what the doctor is going to say, what are the tests that she is going to tell. So all the time they are focused on the doctor. But touch me, in my practice, nobody has ever asked me, like, as a couple, what is something, doctor, that we can do? Okay, so I think it should start with them. Okay, after the initial evaluation is done, see, I always tell, even when couples say that, doctor, is it safe to have only one baby or twin baby? So I always tell them that, see, this is something that you people need to decide, because I'm not going to come to your home and change the diapers, right? So they should be connected. They should have equal involvement in the treatment. And like, fertility is not something like an appendix surgery where the doctor says we have to operate today itself. So it is always something which is mutual. There is always a cafeteria approach also involved. This. There is always a success rate, limitation, pros and cons of all the treatment. And it should be a mutual decision that in which direction you want to go. And there are, of course, certain things that the doctor will help you. But decision is going to be theirs, and involvement in the form of lifestyle, or, coming on time, taking medication, following the doctor's advice altogether is something that needs to be considered.
That was very beautifully put. Thank you so much. Dr. Priyanka, what is your one piece of advice?
I think they need to have clarity. Okay. They should not be confused. Meaning, there's of course advice coming from multiple, forums. It could be social media, it could be your family, friends, multiple doctors. So if you are going to try and understand everything and then be confused, right, then you don't have a direction to go to. So two things. Keep that hope, definitely, because that's what's going to take you there. And keep your trust as well at one place, right? Otherwise, I have patients who've gone to multiple doctors, and it's just a treatment that goes for 3 months in one place, 3 months in another place, 3 months. So how long are you going to do this? Of course, it's not worked out. That doesn't mean that, you keep shifting. So you're going back. Your treatment is not going forward. It keeps going back, and you're stuck in a loop. Right? You need to understand, this is the problem, this is where we are, how we take this forward. So hope and trust. Two things.
I think those are the two beautiful words that a couple needs to constantly keep reminding themselves.
In addition to what she said, even one more thing I would like to add is that comparison. So there are comparison is such a big trap that, Deepika Padukone conceived at 40. Why can't I at 35? Okay, you are not having the same lifestyle, the same luxury the other person may have. Okay, then there is some person, my neighbor conceived at 0.3 AMH. My boss ka IVF failed in the first attempt, will my fail too? So that comparison trap is very, dangerous. And I feel everybody should be focused only on their treatment, and their journey.
Even I think waiting outside,
Yes.
we have long waiting hours, patients waiting outside. So in our fertility department, of course, they're all, fertility couples.
Yeah.
So when they talk to each other, right? So they come and tell us, so that patient, this happened. And it doesn't work like that, right?
You advise this test for that patient. Why are you not advising it to me? It's like that.
I think that's what we've taken from all the conversations, right? Your treatment is going to be customized for you. Take emotional encouragement from your peer, but not technical advice. I think that's our key takeaway. Wonderful. Dr. Deepmala?
Obstetric is ishq for me and my patient also. आग का दरिया है, बस डूब के जाना.
Beautiful. Thank you so much for sharing that, Dr. Pratap. So since we are discussing about the IVF, so for all those, couple planning to go for IVF clinics to get pregnant, for those people who have already undergone the treatment successfully and are pregnant now, and those who are going to be delivering soon, one thing I would like to say is, from my experience, don't think that IVF is bad, or you're always going to have a preterm baby. You're always going to have a baby who's having problem. Those things are the thing of the past. So right now, majority of these babies are delivering at term, and then they're quite healthy, and then they're doing really, really well. For those minority of the babies who need help, people like us are always there. Okay.
That's what we have done all our lives.
Thank you so much. That's very reassuring to hear. I've not started the journey yet, but I'm feeling good to know that there is an entire team at play at this, right? And Dr. Anjali?
I would like to go along the lines of Dr. Priyanka, that trust the team, trust the process, keep hopes up. And this is just a chapter, and keep your hopes up so that, you see the whole story unravel in front of you.
Beautiful. I think very beautifully we've covered this entire journey. I hope that whoever is watching this were encouraged, some of their fears were dissolved by just knowing. Like I said, fear decides where understanding lacks. So I want to thank all of you. I know you've spent hours being here, but these hours can change a lifetime for somebody else. So I want to thank you everyone for your time, and thank you so much for so openly sharing the experience, something that people always hold to themselves. You all came and so openly shared. That is beautiful. This was a lovely conversation with all of you. Hoping to see you all again in the future. Good luck. So this was our conversation with 5 leading specialists from Motherhood Hospitals. If you found this video informative, do share this across your loved ones. Share it with a woman who's wanting to be a mother. Most importantly, share it with a man who wants to be a father. Wishing you all a World IVF Day.